Good morning, everyone. It's my honor and privilege to introduce Dr. Phillip Littlefield, who retired from the U.S. Army after 20 years as a military physician, to include being a program director at Tripler Army Medical Center, where I trained, and is one of the reasons that I myself became interested and pursued the field of neurotology. He previously trained at the Northwestern University for his neurotology fellowship. He has always been passionate about teaching, and his primary interests are chronic ear disease and blast injuries to the ear. And today he will be giving a talk to us about otologic blast injuries and their management. So thank you kindly, Dr. Littlefield, and take it away.
Thanks, Mike. Thanks for the introduction. It's a real honor to be invited to speak at the House Clinic, so thank you. I've given at least 100 presentations in front of a crowd, and I'm pretty comfortable with that. But this is my first presentation on Zoom, so this is uncharted territory for me. I already don't like how I look in the camera, so I'll try not to look over there too much. It's a little bit intimidating speaking at the House Clinic because there's so much expertise there. So I wanted to put my best foot forward with something that I have a lot of experience with that might be unique to a lot of you, and that would be blast injuries. A couple of disclaimers. I'm at home. My 2 teenage sons will be going off to school during this, so there might be some complications with that. And there's a couple of dogs in the background too.
Well, be sure you have your kids tell us.
Disclosures. I'm a shareholder for Frequency. I don't think there's any interaction between that and this. I've also been an expert consultant in the 3M Combat Arms earplug litigation. I don't think there's any interaction between that and this either. The only thing I'm going to say about earplugs is that they work. I'm not going to be speaking about hidden hearing loss. I will be talking about one case where I think that hearing loss progresses after the noise exposure, but this was an individual who's not wearing earplugs. So the first thing, which I obviously think is true, is that this is a relevant topic. My experience was out of Iraq and Afghanistan while I was at Walter Reed, but also while I was in Iraq itself. But you know, we've been out there for a while, but as Ukraine shows, war is not too far away, and lots of eardrums are being ruptured over there right now. And I'm sure some of us will be repairing some of those perforations, Russian or Ukrainian. And fortunately, we haven't had any terrorist incidents lately with explosions, but the Boston Marathon bombing reminds us that something like that can happen near us, and we should be prepared to be able to help whenever something like that happens. With the Boston Marathon bombing, there were over 60 eardrum ruptures and untold other injuries. And I certainly hope nothing like that happens anytime soon. So here's my objectives, and they're already up there before. There are actually 5 in Mike's slides, and I have 4 here. I'm not sure what I did. But we'll talk about acute management of blast traumas. That's basically acute hearing loss and tinnitus after a large noise exposure. Then what to do if there's a perforation of the tympanic membrane. Then I'm going to talk about more chronic management, basically Tympanoplasty. And then I also want to touch on the vestibular side at the end. I spent 12 years doing a multidisciplinary vestibular clinic on blast injured patients, both at Walter Reed and at Tripler Army Medical Center. That was with a neurologist and an audiologist and a physical therapist. And I learned a lot from that and saw countless patients. So I'd like to share some of that. I have several publications on this topic. The first one was a year of experience where I took my cases from Walter Reed Army Medical Center and combined them with Arnaldo Rivera, who was a neurologist at National Navy Medical Center in Bethesda, Maryland. Arnaldo is now at the University of Missouri. And then I took 5 years of my own cases and published them separately with Sunjin Song and Schenker Schroeder, both former residents of mine. I'll be presenting this data in more detail. This is 2007 through 2012, but I've certainly repaired plenty of blast perforations after that period until I got out of the Army. Even after getting out of the Army in 2019, I've repaired a couple from blasts that were sustained in Iraq and Afghanistan. And I've had a couple of patients of mine from the military who have come back to me in my civilian practice. And it's always a pleasure to have that experience. I'm also going to be talking about the Boston Marathon bombing. Both Aaron Remenschneider and Dan Lee are friends of mine. Aaron and I are co-authors on a couple of presentations, and Dan and I have been good friends for a long time. There's actually a lot of publications on terrorist bombings from Northern Ireland, Croatia, Finland, England, Israel, but most of them lack good audiologic data. It's very categorical, and we'll just say hearing loss or not hearing loss without giving any numbers. More recently, and especially with this, we have much more precise data. This paper is also interesting because they show where everyone was in relation to a blast and how far away, and I think that's interesting. I didn't have the same granularity with the people I saw with injuries. This is two worlds colliding. So I was in Hawaii 3 weeks ago for the UCSF Pack Rim Otolaryngology update, and Dan Lee and Sujin Song and I went out for a round of golf and had a good time. So acute management, here we're talking about basically acute noise trauma. We all have experience with this. I have to say, I don't think I have a tremendous amount of experience with this compared to many other people, just because most of my patients who were wounded in combat were wearing earplugs and did not have a lot of auditory injuries. The ones that I did see with auditory symptoms had tympanic membrane ruptures and were not wearing earplugs. Speaking of, with most series of people wounded by explosions, tympanic membrane perforation is the most common injury. So for example, Boston Marathon, about 90% of people who were hospitalized had tympanic membrane ruptures. Other terrorist series show similar, but in my series and data out of Iraq and Afghanistan, we were only seeing about 10 or 15%. And I think that's because most of our individuals were wearing earplugs. But when I was in Iraq, I occasionally would get a patient who was near an explosion and was not wearing hearing protection, would have hearing loss or tinnitus. By the time they got to me when I was at Walter Reed, the injury usually had been a couple of weeks before. So that was sort of a different routine. And even now, of course, I see people who will shoot a firearm or be near an explosion or a siren from a fire truck or something and have acute hearing loss. And I think that our approach to that is similar to what we see with combat and terrorist explosions. So the first thing you always hear is you should have a timely audiogram, and I agree with that. It's always nice to see what you're dealing with. However, I don't withhold treatment until I see the audiogram. In my practice, my group, it's pretty hard to get an audiogram, and I hate to disrupt the schedules to immediately get one. And I'm sure a lot of us, for example, with sudden sensory hearing loss, if we get called by a primary care physician, we'll say, please go ahead and start them on some prednisone, and we'll get them in and take a look at them and get an audiogram, but we don't delay the treatment unless there's contraindication to steroids. As far as acute hearing loss or tinnitus with steroid treatment, there's not really a lot of good evidence-based medicine for oral or systemic steroids. There's no randomized controlled trials. There's no prospective series for oral steroids. We'll talk about transtympanic where there is, but papers on this will say that there is not a lot of evidence and then say that systemic steroids are the standard of care. And I would agree with that. I think that the rationale comes from animal data, and animal data is pretty clear that steroids, however delivered, are protective with noise trauma, whether it be continuous noise or impulse noise. And generally rodent ears are the same as human ears, although they seem to be able to recover more to normal and more quickly than human ears do. And I think it's reasonable to extrapolate a lot of that data and use that even though we don't have good prospective studies, and I think it'll be hard to ever have them. So how do I approach oral steroids? I basically use the same strategies that we use for sudden sensory hearing loss in our clinical practice guidelines. So if somebody comes to me with hearing loss or tinnitus, I will get them on high-dose prednisone, usually 60 milligrams a day for 7 to 14 days, and then a taper over the next week. The duration depends on usually how much hearing loss they have and how quickly they respond to the initial steroids. Of course, there's contraindications that we're always taught about, acute closed-angle glaucoma, active tuberculosis, recent psychosis from steroids, but those are unusual. The most common thing that I encounter is poorly controlled diabetes. And in some of those patients, I'll offer trans-tympanic steroids instead of oral steroids. As far as trans-tympanic steroids go, we do have a randomized controlled trial out of China on this. It's an interesting study. I was reviewing it this week to make sure I had it right. But these were individuals who had acute hearing loss from noise exposures within the last 10 days. And they had audiograms that showed significant hearing losses. And these individuals were hospitalized. And if they had a quick spontaneous recovery, they were enrolled in the study. But if they did not, then every patient was placed on IV solumetrol, methylprednisolone. And then there was a treatment group where they had every other day injections of dexamethasone for 10 days. And there was a significant difference between these groups. So they defined an improvement in hearing as 15 decibels or more improvement. And in the systemic steroid only group, the response rate is around 25%. And in the trans-tympanic, in addition to systemic group, the response rate was 50%. So with that data, it's hard not to offer trans-tympanic steroids in people with significant hearing losses after a noise exposure. I'd like to see an audiogram first and see how much hearing loss I'm dealing with, but I find the study pretty convincing and don't see any serious flaws. Of course, with anything like this, I'd love to see some replication of the data, but I haven't seen anything recent. Inositol comes up, and actually a lot of other compounds come up, but I wouldn't offer anything instead of steroids, only in addition to steroids. I think looking at the animal data, that there is a small otoprotective effect to inositol, but the data is a little bit more conflicting than with steroids. I do offer this on occasion when people have acute hearing losses from noise, but I often have to look up the dosing to remember how to do it. Currently, I use the dosing that's in a DoD study for traumatic brain injury. So that would be oral tablets. I do 4 to 8 milligram loading dose, and then 2 grams twice a day for 7 days. But there are other strategies. Inositol can be hard to get hold of as well. So you have to check the pharmacies, and sometimes you have to use the ampules. And if you've ever opened one of those, they smell terrible. They smell like rotten eggs. I have a lot more experience with this actually than with the intact tympanic membrane. So you have somebody with an injury and there's a hole in the eardrum. One unique aspect of this for me is often I couldn't ask them about hearing loss or tinnitus because they were unconscious. I'd see a lot of these patients at Walter Reed and they'd be on the ventilator. And so I just had to assume that they had a sensorineural hearing loss from the blast, or were very likely. And I'll touch on that in a bit, but about a third of these people do have a sensorineural hearing loss from the blast if the eardrum's ruptured. At first, early in my experience, I spent a lot of time trying to examine these patients at the bedside. It's a rare patient that can come into your office, and you can examine them with a microscope in your office. Usually they have multiple injuries. My typical patient was in the intensive care unit, had multiple amputations, or at least one amputation, multiple lines. You just couldn't get them in there. So we come to the bedside and examine the ear with a speculum and a headlight, tried to debride the ear, examine the eardrum. But I stopped doing that when I realized that these individuals usually have to go to the operating room multiple times for other things. With mine, they had amputations, debridements, abdominal wounds, and so on. So I would just kind of hijack the OR and go in there and get the microscope and examine them while they're under anesthesia. The trauma surgeons, general surgeons, orthopedic surgeons usually didn't mind. And if they did, they usually abided anyway, because we didn't take very long. So if you examine the eardrum in the operating room, I would take time to unfurl the perforation. We'll talk about this in a bit, but a lot of these, the edges can wrap under and cause pearls of cholesteatoma. I had to debride it, but it's not the time for tympanoplasty. I'll support the edges with gel foam. Gel foam and what I'll explain in a minute, but this isn't time to harvest fascia or anything like that. I've been asked about things like epithelial-derived growth factor at this time. I know there's some studies out of China, for example, that show this can help with spontaneous healing of these perforations. But the more recent study by Brad Welling, which was a randomized controlled trial, unfortunately didn't show a big difference, a significant difference between the groups. Not advancing for some reason. Let me try this again. Okay, so the question always comes up in each of these cases, can we use systemic steroids? I like to use systemic steroids when there's a significant RL trauma, but a lot of times the trauma surgeons, orthopedic surgeons don't like that because there's amputations they're trying to heal. So it's definitely a multidisciplinary discussion. Certainly if you can't, there's always the topical option. And for example, you could use steroid drops. I actually have not done that, but it is an option. One thing I did do a lot of was ciprofloxacin and dexamethasone drops. I don't use fluoroquinolones for a clean perforation, but if they were contaminated, I would. And the logic behind that is the research that Patrick Attinelli has with fluoroquinolones delaying healing of the tympanic membrane. I have to say that I haven't really seen that as a clinically significant issue in my own practice, but I don't see the need to use fluoroquinolones when it's a clean perforation. However, I will directly contradict myself in a moment and say that I will put high dose steroids on an acute perforation, even though I know it delays wound healing. I'd much rather have a perforation that I know I can repair versus a permanent sensorineural hearing loss or permanent tinnitus that I can't do anything about. So early on in the series, I just started putting gel foam soaked with dexamethasone in the middle ear. I put it right against the round window membrane. At the time, it was the 4 milliliter concentration, but now if I see acute perforation from whatever, here it's more often surfing, but if I see acute perforation, I'll put the 10 milligram per milliliter dexamethasone on gel foam in office, usually just put it right against the room window. That's a significantly stronger concentration than you get with the ciprofloxacin and dexamethasone drops, where it's only 1 milligram per milliliter. So key points, we don't really have a lot of strong evidence-based guidance for this, except we do have one good randomized controlled trial out of China that shows that trans-tympanic steroids are beneficial in addition to systemic steroids for acute hearing loss in individuals who did not have tympanic membrane perforations. I think given the risk to benefit, that it's reasonable to be aggressive with steroids and other otoprotectants in addition to the steroids. This is one of those few opportunities where you have a chance to prevent a irreversible injury, and especially so with tinnitus. Okay, now I'm going to talk about my tympanoplasties. From 2007 to 12, I did 87 of these for blast injuries. I have 68 that had enough long-term follow-up to present. A lot of the other ones were lost to follow-up because they would go off to other VA hospitals, and I just didn't have visibility of what happened to them after that. I believe I have the largest series of any military surgeon in the United States. There's certainly a lot of other military surgeons with experience with this. So I'll give shouts out to Mike Hoffer and Mark Packer, Jim Crawford and Arnold Rivera. I know that while I was in the thick of this, they were also repairing these perforations, but I know I have the largest published series. This isn't the largest series overall for blast injuries. There's one out of Croatia from 2001 with over 100 perforations. So in my series, I found 10 with cholesteatoma. All of the cholesteatomas were from the edges of the perforation, and these were either anterior or inferior into the hypotympanum. The Boston Marathon series showed similar rates, and in their series, they also were all anterior or inferior. There have been other publications that have also said that fragments of the tympanic membrane can be implanted into the middle ear and form cholesteatoma. I have not seen that in my own practice, and that was not seen in the Boston Marathon series either. I'm not sure it's possible for that to happen. It would take a lot for a little fragment to take, but I can say with my numbers that it's not feasible. I just haven't seen it. I saw 6 vesicular injuries. So twice I saw that the stapes foot plate was fractured off of the superstructure. Twice I saw the pseudostapedo joint separated, and twice I saw that the incus was completely absent. The one where the incus was completely absent was actually the same person, both ears. And I ultimately did bilateral implants on him. And in both implant surgeries, I found the incus in the mastoid, and it was still attached at the posterior ligament, but had hinged into the mastoid. I also saw 3 with shrapnel in the middle ear at the time of tympanoplasty, but I know there were a lot more that we debrided prior to surgery that had shrapnel in the ear. And I also had 2 perilimb fistulas. Both of those were individuals with vesicular injuries, and the stapes foot plate was cracked from top to bottom. Both those individuals had sensory hearing losses that went with the perilimb fistulas, but after the fact, when I talked to them about it, neither one was dizzy. I might forget to mention perilimb fistula later when I get to the vestibular part, so I'll just mention it real quick right now. I've explored 3 blast patients at Walter Reed who I thought for all the world had perilimb fistulas after ruling out other possibilities, and all 3 were negative explorations, and one was even more dizzy afterwards. So I would warn you to be careful about perilimb fistulas in this population. In general, I'm not a perilimb fistula person. I had to be very impressed before I'll explore somebody. And I haven't explored anybody in several years, but I do keep that in my differential diagnosis for people with auditory and vestibular symptoms after ear trauma. So what kind of perforations was I dealing with? Well, a little over half of my patients had bilateral perforations, and the majority had either total or near total perforations, over half. So this is different than the Boston Marathon series, where over half had just one quadrant injured. These are not your typical perforations that you see with chronic ear disease. Less than 20% were posterior only, or your posterior inferior. I actually only had 4 perforations that were the posterior inferior quadrant. I repaired all 4 by a transcanal underlay, and all 4 worked, but the rest were much more involved than that. This is just to show how severely injured my patients were. So 43 of my patients had at least 1 amputation, and 23 had bilateral leg amputations, which is unbelievable if you really think about the morbidity that we were dealing with at that time. And I had patients with over 40 intubations, and we'll touch on that, but you don't want to just jump on Tympanoplasty and then find out that they have to have multiple other surgeries, because they're going to get masked and they're going to have multiple opportunities to displace their grafts. As far as tympano timing goes, I would wait at least 6 weeks, just like we normally do with acute ruptures. I actually waited a lot longer. My mean time in my series was 152 days. There were a couple that I repaired at 30 days because they were going elsewhere, and I knew that they would not have good access to an otologist. But in general, I'd wait a long time. Again, most of these people, at least in my series, had a lot of other injuries to be dealt with first, and these can wait. And that was true at the Boston series too. Most of the patients waited at least 6 weeks before any repair. Of course, if the perforation healing, you're going to let heal longer. I can say that of the total perforations or near total perforations, I did not see any spontaneously heal. But the smaller ones, I certainly did see a lot heal. I think my hunch for my own patients was about half healed. In San Antonio, there's a paper by Amber Rittenauer where about half of the people hospitalized with perforations healed spontaneously. And I would be very careful with these patients to coordinate with physical therapy. A lot of my patients would get repairs and then be off doing therapy the next day or the day after. And I had to be very careful about that. I know I had one patient who had a failure who went kayaking just 10 days after surgery. It was an expedition with PT, and I certainly would not have approved had I known about it. So be careful. So this was my initial Tympanoplasty strategy. I'll give you a little bit of backstory first. When I was a resident, the first way I really learned how to do Tympanoplasty was a lateral graft, because I had an attending, Mitch Ramsey, who was fresh out of a fellowship at Mass Pioneer, and Mike McKenna taught him how to do lateral grafts, and he used that for almost everything. But when I went to fellowship, we never did a lateral graft. I don't ever remember Richard Wyatt doing one, and he got good results. But the more I think about it, we avoided the total perforations. And, you know, we see that in our own practice. You see somebody with a total perf who has had it for many years and has some tympanosclerosis. They probably grew up in the Philippines or somewhere like that. And you're really hesitant to offer them surgery because you know it's probably not going to work long term. And I've tried it before, and you know how sometimes the hearing can be even worse if you repair a perforation in somebody with tympanosclerosis. But in somebody with a blast perforation, you're eager to fix a total perforation. And when I first came out of fellowship, I used the anterior tab pull-through technique. And I'll show you a picture of that in a moment. But as I went on, I switched to the lateral graft. And personally, I feel that I get better results for the large perforations with lateral graft. For the smaller cases, I used a posterior fascia underlay. Almost all of them were with the postauricular approach, but I did have 4 where I just used a transcanal approach. Again, at first, I rarely did lateral grafts, and later on in my series, I did almost exclusively lateral grafts for the large perforations. So this is the anterior tab pull-through technique. I don't know if you can see my cursor, but basically, you elevate the posterior annulus and the anterior annulus, and you bring the graft up under the anterior annulus and against the ear canal bone anteriorly. I think this is a good technique, but you can have problems right here inferiorly at the inferior annulus because you're supposed to leave that attached at 6 o'clock. Honestly, nowadays, I tend to go ahead and just elevate that anyway if the perforation is close there. And then you can also have trouble up here at the most anterior superior part. And nowadays, if there's a perforation there, I'll avoid this technique. So my results, I did 68 repairs, and overall I had a success rate of 77%. So 52 of these were successful. I'm being a little bit unfair to myself. If I had a total perforation and there was a pinhole when it was all over, I counted that as a failure. And I had 3 just like that. But 70% of my underlays and 82% of my lateral grafts were successful. If we compare the underlay versus the lateral graft, we find that it wasn't a statistically significant difference, but I feel that there was a difference between the two techniques in my hands. My repair success rates also improved over the study period. And, this is expected. It was my first 5 years out of fellowship, and there was a learning curve. And heck, now I'm 15 years out and I'm still learning how to do these cases. But my success rate my first year was 66%. And my last year, it was 91%. And I think the biggest difference was that I stopped trying to use the anterior tab pull-through technique for the larger perforations and switched to the lateral graft. Regardless of technique, my results improved over the years. And when you ran the statistics, the size of the perforation did not significantly correlate with the success rate of the Tympanoplasty, but I think I got better with my technique choice as the series went on. So right now, here's my strategy. If it's a total or near total perforation, I do the lateral graft. And my technique for the lateral graft, basically, you can take the Brackman surgery of the year textbook and the chapter by James Sheehy. That's how I do it. The only difference is that I like to use the rosebud soap dressing. And a few years ago, I was watching a presentation on endoscopic lateral graft Tympanoplasty. And instead of cutting a slit in the graft, they just poked a hole in it and then ran the malleus handle through that hole. And I thought that was pretty clever, so I've been doing it that way since. For the subtotal perforations, as long as it's not the anterior superior quadrant, I still use the anterior tab pull-through technique. And if it's a relatively small perforation and the anterior superior quadrant is involved, I started using the over-under technique, also called the lateral to malleus underlay. I didn't really know about that technique when I was doing this series. I remember seeing Dave Haynes present the Vanderbilt experience at COSM in 2014, and he kind of got lambasted by the audience about the results. But after seeing that presentation, I was thinking, this is pretty honest data, and I think there's a lot of merit to this technique, and that's when I started using it, and I think it's a good technique. My hearing outcomes, so preoperative, the air conduction thresholds were 27.7 decibels, postoperative 11.7 decibels. This is excluding those who needed synechoplasty. I think those are pretty reasonable results. And that was with 4.3 month follow-up. I will say that everyone who had a Tympanoplasty, or nearly everyone, had a pre-op audiogram at the bedside. So there was a lot of background noise that affected my hearing results. Almost over half of my patients were on prophylactic anticoagulation. I did not stop the prophylactic, so Lovenox, for example, I did not stop any of my patients. There were some on Coumadin or therapeutic heparin that I did stop, but I didn't have any bleeding complications. So I wouldn't worry too much about Lovenox or low-dose heparin. So the key points, I think that the techniques you already know for chronic ear disease work well, but I do prefer the lateral graft for the larger perforations. I'd be careful to look for cholesteatoma and the protympanum and hypotympanum. The Mass Eye and Ear group recommends using an endoscope for this. I did not in my own series, but I think that's reasonable. You get a really good view. I'd be careful to inspect the ossicular chain for injuries. Of course, you should with every Tympanoplasty, but more so with this. And I'd be suspicious for perilymphatic leaks and injuries at the stapes foot plate. So I've also taken this data and looked at the long-term hearing outcomes. One of the benefits of my data is that all my service members had audiograms when they joined the military. So I actually had pre-injury audiograms and could see how their thresholds shifted with the injuries rather than just presenting their absolute thresholds. A lot of these had some pre-existing sensorineural hearing loss from noise exposures, and I was able to account for a lot of that. So I ended up having 49 patients who had both pre-injury and fairly long-term post-injury data, over 522 days post-injury data. So this is a little bit busy, but I broke this down into bilateral perforations unilateral perforations, and then no perforations in one ear. And this is broken down by percentiles. And we have the solid lines here. So those are people who had major sensorineural threshold shifts, and I've excluded them from the data analysis as outliers. So the first thing you see is I have 6 people in the bilateral perforation group who I excluded because of major sensorineural shifts, but none in the unilateral data. And then there's just 1 in the non-perforated. So it seems that if you have a bilateral perforation, that you're more likely to have an injury with a major sensorineural shift. And that makes intuitive sense that perhaps people who had bilateral perforations were exposed to higher energy blasts. The next thing you see is that a lot of these individuals don't really have major sensorineural threshold shifts. About half of patients have 10 decibels or less shift, and a lot of them don't have any shifts at all. But there is a group where you see here the 90 percentile group in the bilateral set here, where there's shifts of close to 40 decibels. And I'll explain that some more in a minute. The other thing that I saw with this is that the data is relatively normative data once you take out the outliers. So this is the mean threshold shifts by frequency. So the blue diamond is the non-perforated ear group, and you can see that there's really not much of a threshold shift in the side without the perforation. Of course, my assumption here is that the side without the perforation was exposed to less energy from the blast than the side with the rupture, but we don't know for sure. We didn't have sensors on either side when the injury happened. But it seems reasonable to make that assumption. Here we see that the unilateral group seems to have more sensorineural shift than the bilateral group, but remember that the unilateral group here is smaller and that the outliers were removed. So this is actually not a statistically significant difference, and I think we're just seeing some noise in the data. But what we did see, so 83 consecutive people with blast injuries significant enough to cause perforations of the tympanic membrane, we get a bimodal distribution. So 5 to 13% of these individuals had a shift of at least 30 decibels and averaging 30 decibels. And then there's 87 to 95% where the shift was only about 7 decibels. And I had 70% with 10 decibels of shift or less, and about 50% that didn't have any shifts at all. So you could rupture your eardrum and not have any measurable sensorineural hearing loss by pure tone thresholds. But some of those individuals have severe to profound losses. I spent a lot of time trying to figure out why that is. And I think that the biggest factor were the individuals who had acicular injuries. So everyone who had a acicular injury had a sensorineural hearing loss. And 3 of the 6 with the acicular injuries had profound hearing losses. I also found that 6 of the 7 profound hearing losses were in those with bilateral perforations. And I think it just has to do with the energy of the blast. However, we didn't find any differences by age, by size of the perforation. I wish I could also give you some data on when steroids were used, but it's too messy, so I didn't. I did find that the shifts were more likely with the total and near total perforations. That was a trend, not a statistically significant difference. And also those with non-perforated ears were not more likely to have hearing loss than the perforated side. The reason I mentioned this is there's been some prior studies that say rupturing the eardrum can be protective to the inner ear, and that the eardrum and the acicular chain can be sort of a barrier that absorbs energy to protect the inner ear. But that doesn't seem to be the case with my data. The other thing that I saw is that the shifted audiograms had notch patterns, a lot like noise notches, but they're flatter than the typical 40 kilohertz noise notch that you see with continuous noise. So Doug Brungart did this for me, but he took 12,706 hearing conservation audiograms in service members, and then plotted that against my cases with perforations. This is the slope of the audiogram. And we just see that these individuals have a lot flatter audiograms than typical service members who had, say, impulse noise exposure from firearms. This is different data. This is not my blast patients. This is 180 consecutive patients at Triple Army Medical Center that had MRIs for asymmetric sensorineural hearing loss. All of these were active duty service members with noise exposure from firing weapons. And what you see is that most of the asymmetries are in the left ear, which is not surprising for, as we all know, most people are right-handed and fire weapons right-handed. When you do that, you're more likely to have hearing loss in the left side from the noise. But I also found that my asymmetries were not just at 4 kilohertz, like you see with continuous noise data. I saw a lot of 3, 4, 6, and 8 kilohertz asymmetries. And actually in the military population, I found that the 6 kilohertz predominated more than the 4 kilohertz. These aren't the ruptures, but I think that's interesting data for all of us. This was my one individual that I did a cochlear implant on. And as far as I know, he's the only person from Iraq or Afghanistan that required a cochlear implant. Again, when I did the surgeries, I found the incus and the mastoidantrum on both sides. What's interesting about his data, and this looks a little messy, but the green is bone conduction from 2008, and the blue is a 2011 audiogram. And what I found was that in the low frequencies here, his hearing loss progressed over that 3 years. And I had a couple other cases in the severe to profound hearing loss group where the hearing loss progressed years after the noise exposure. However, I did not see any progression of the hearing loss overall in my data. I personally think that there can be some progressive sensorineural hearing loss after a noise exposure that causes a measurable sensorineural hearing loss. But with my data, with the 5-year period maximum that I looked at these patients, I was unable to show that, and therefore, and have not published any significant findings. I want to touch briefly on traumatic brain injury or vestibular in the few minutes I have left. Again, I've seen countless patients with head traumas from Iraq and Afghanistan, blasts, but a lot of these individuals also hit their heads at the same time, either on the ground or on the sides of vehicles. Some of them even had penetrating traumas from these injuries. And my take on this is we can have a lot of vestibular or vestibular-like symptoms, but there's usually more than one thing going on. And when somebody comes to you with a TBI after this, it's usually a collection of things that you have to figure out. And it can be really difficult parsing these out, but here's common things I saw. Yes, there's a traumatic brain injury in a lot of individuals. I did see a lot of people who I think did not have a TBI, but did have separate vestibular injuries, but I saw a lot of people who were being treated for TBIs. I thought a lot of these people gradually improved over 18 months or so. Mike Hoffer published that a lot of people with TBIs from combat will have vertigo after a few minutes of exercise, say with jogging. And I thought that was curious, but wasn't, I guess, I'm sorry, I have a dog here, wasn't exactly convinced, but then I did start seeing that in my own patients. So don't be surprised if you have somebody with a TBI who says, well, I tried to go out jogging or some other exercise, and after a few minutes of intensity, I started getting vertigo. I find that those people tend to have migraine-like symptoms and they respond well to migraine treatments. Again, a lot of these people do have migraine-like headaches. I tend to leave that to the neurologists these days and have them try to treat those headaches, especially since there's so many new medications for migraine. I will say back when I was in the military, I did prescribe a lot of migraine medications for these individuals, but I tend to leave that to the neurologists now. I did see a lot of peripheral vestibular injuries into these individuals, the so-called labyrinthine concussion. I don't know if that was caused by the blast itself or a blunt head trauma, but a lot of these individuals have that. course, there's PTSD. There's a ton of BPPV, and that makes sense. You have a head trauma, then you're laying flat for aeromedical evacuation, transport, multiple intubations where your head's put below the plane, below the horizontal plane. So definitely look for BPPV in these individuals and treat that. A lot of medication side effects, a lot of cervical disequilibrium. And then another thing I saw a lot of was autonomic dysfunction. You have people who are staying in bed for months, and then they get out of bed, and of course they're going to have some lightheadedness and dizziness. And as we know, the vestibular system also has some autonomic connections. So a peripheral injury plus being bedridden can give you significant autonomic dysfunction. Am I doing all right on time, Mike? Okay.
Doing fine.
Okay, there's just a few more slides here. This is me doing a epi on somebody about a dozen years ago when I looked a lot younger. At the time, I always had V&G goggles and would examine all of these patients in my multi-D clinic with V&G goggles. It was a luxury, but really look for BPPV in these head trauma patients and get rid of that before worrying about everything else. So, of course, this is a superior canal dehiscence. This is an individual I saw who was next to an IED when it blew up. He did not rupture his eardrums, but he had classic SCD symptoms afterwards. I repaired it by a middle faucet approach and he got better. I wish I'd written it up because it would have been the first case report of SCD after head trauma. And now there's several. Actually, in about an hour and 15 minutes, I'll be doing a superior canal dehiscence. So that's why I'm already in my scrubs. But do look for these with the head traumas. But you've been warned about the perilymphatic fistulas. I'd be a lot more cautious about exploring those. So key points with vestibular. There's often a combination of conditions in these head trauma patients. Look for BPPV, cervical disequilibrium, and autonomic dysfunction. The headaches need attention. This is common, things happen commonly before looking for the zebras. And then these patients do well with abundant physical therapy. Certainly getting them out of bed and moving around more is very helpful.